classes which can be accessed anytime, anywhere for all your subjects. And there are notes available. There is a ultimate comprehensive books which is based on the latest CBME syllabus, and then apart from that you have MCQs as well. Then here at Oracle, we also have personalized counseling sessions. So apart from the academic support, if there's any extra guidance and support that you want from us, you can anytime feel free to book a slot with us for that extra guidance. And we have 3 different subscription plans at Oracle, starting from basic, which is for 3 months and will cost you 15,000. The standard, which is for 6 months, it comes at 30,000, and the premium plan, which is for 12 months, and it comes at 50,000. In the premium plan, you also have the option of live doubt clarifications, and there is also one-to-one personalized guidance. Then you can use my promo code as displayed here on the screen to get additional 20% off. Then briefly introducing you to the internal exam marathon series. This series has been specifically curated to focus towards your university exams, which are approaching in a while. So this is a rapid revision of all important topics. All volatile facts will be covered. Here, multiple 12 questions will also be there so that we can assure you top-notch grades in your exams. Okay, so although today we'll be talking about ketone bodies, but yesterday there was a lot of disturbance during HDL metabolism owing to the internet. So I'll quickly recapitulate that, although this had been done, but I'll just recapitulate it, okay? Since there was a lot of hassles yesterday while I was taking this. Okay, so beginning with HDL metabolism. So we had spoken that HDL facilitates reverse cholesterol transport, okay? Reverse cholesterol transport. That is why it was referred to as good cholesterol. The factors which help HDL to facilitate reverse cholesterol transport are your LCAT activity, ApoA1, which is present in HDL. It is the activator of LCAT. And then there are transporters. These transporters are present in peripheral organs, which help to transport cholesterol and cholesterol esters from peripheral organs to the HDL. So with the help of these 3 functions, the HDL is able to carry out its function of reverse cholesterol transport. Okay, let's understand the metabolism of HDL with the help of this handmade diagram. So your HDL, it is being secreted from both intestine and liver. Okay, it is secreted as nascent HDL. Nascent HDL, which is discoidal. So the nascent HDL, which is secreted by the intestine and the liver, it is discoidal in shape because it is rich in cholesterol and phospholipids. And these cholesterol and phospholipids, they are amphipathic. So anything which is amphipathic, it cannot form a spherical structure. This is cholesterol plus phospholipids. Okay. So it cannot form a spherical structure. It is always present in the form of a bilate, just like a plasma membrane. So your nascent HDL, it is discoidal in shape because of the presence of, it is rich in cholesterol and phospholipids. Now what happens? The ApoA in the discoidal or the nascent HDL, it activates the LCAT activity. You can see this ApoA is activating this LCAT activity. As a result of activation of LCAT, what happens? Your cholesterols are converted into cholesterol esters. So when this LCAT is active, what happens? Cholesterol is changed into cholesterol esters by the activity of LCAT. Now these cholesterol esters, they are hydrophobic, so they will be internalized, leading to the formation of a sphere. So your discoidal HDL, it transforms into a spherical HDL3 because your cholesterol ester, it is hydrophobic. So it will be internalized. So as a result of which your discoidal nascent HDL, it changes into spherical HDL3. Now what happens from the peripheral tissues? This is your peripheral tissue. These peripheral organs, they have transporters. These are transporters, okay? So these organs, they have transporters, and with the help of these transporters, the cholesterol from the peripheral organs is transferred to the spherical HDL3. Now, in the spherical HDL3, what is active? LCAT is active, as a result of which the cholesterol is converted into cholesterol esters, and these cholesterol esters, they are internalized. So there is more space in the periphery. So more and more cholesterol can be transferred from the peripheral organ to the HDL3. Now, because of this, what happens? This spherical HDL3 is converted into spherical HDL2. Now, the spherical HDL2, which is loaded with cholesterol, it donates its cholesterol to the liver, and in the liver this cholesterol is converted to bile acids and secreted. So this cholesterol that is being secreted from the liver, this is liver, okay, which is liquid secreted from the liver, it is basically the cholesterol of the peripheral organs. So cholesterol from peripheral organs, okay. So this is how your HDL is involved in reverse transport of cholesterol. You see, cholesterol from the peripheral organs has been transported to the liver, and from the liver, it is excreted as bile acids. So that was briefly and quickly about the HDL metabolism. Although this was taken yesterday, but because of connection issue, I thought I'll just summarize this once again. Okay. So beginning with today's class, that is ketone bodies. So introducing you with the ketone bodies, firstly, we should know that what is the concept of ketone body synthesis and when does it take place. Okay, so in the early fasting state, we all know, which is from the 4 to 16 hours, your glycogenolysis is taking place. That is, your glycogen reserves are being used. So after 16 hours, when the glycogen has been depleted, what happens? Body enters the second stage of fasting. That is the 16 to 14 hours after, and here what is happening, the gluconeogenesis is happening. So the body is synthesizing glucose. Now after the availability of gluconeogenic substrate is restricted and the oxaloacetate availability is restricted, what happens? You enter the starvation state or the prolonged fasting, where what happens? Beta oxidation produces acetyl-CoA, but the acetyl-CoA, it cannot enter TCA cycle because of the unavailability of the oxaloacetate. So the other pathway that is left for acetyl-CoA is that it enters ketone body synthesis. So this is where your ketone body synthesis is coming into role. And these ketone bodies, they are the alternative metabolic fuels. So they serve as metabolic fuel for extra hepatic tissues. Now, this statement that fat burns in the wick of carbohydrate, explain. This is quite frequently asked in examinations. So you might get this statement which says fat burns in the wick or in the flame of carbohydrate, and explain. So let's have a look at the reason for this. So acetyl-CoA produced during beta oxidation has two fates. It can either enter TCA, but you see, your oxaloacetate has been depleted in the previous state. Why has been oxaloacetate depleted? Because of gluconeogenesis. Okay, so this has been depleted because of gluconeogenesis. Now what happens? The other fate which is left for acetyl-CoA is to enter ketone body synthesis. So therefore it says that your fats burn in the wick of carbohydrates. That is, for the complete oxidation of your acetyl-CoA, it needs to enter TCA. But it cannot because your oxaloacetate is unavailable. So this explains the above statement of why your fat needs the wick of carbohydrates in order to get completely metabolized or burned. Okay, now moving on to diabetic ketoacidosis, very important, okay? You might get it as short note in your theory exams. You are often frequently asked about diabetic ketoacidosis even in your vivas. Okay, so this is important. Let's understand the concept of diabetic ketoacidosis. So decreased insulin, that is your Diabetes. Okay, so the level of insulin in your body is decreased, although the blood is loaded with sugar. So there is sugar in the blood, but the insulin level is decreased. So as a result of which, your sugar, the glucose that is present in the blood, it is not able to enter the cells. So for the cells, they think that there is a state of starvation. So what happens? The cell will try to increase the synthesis of glucose, because for the cell, no matter how much glucose is present in the blood, as long as it is not entering the cell is not able to enjoy the benefits of the glucose. So for the cell, it is in a state of starvation and it will try to up the level of glucose. So for that, it increases its gluconeogenesis. Okay, so it is kind of worsening the situation. Now, another point, if you remember, I told you that in adipocytes, what is happening? Your triacyl glycerol is converted into fatty acid plus glycerol, and this is brought about by hormone sensitive lipase. And this hormone sensitive lipase, it is inhibited by insulin and it is activated by glucagon. So this is the scenario of diabetes. So this insulin is low. So when this insulin is low, what will happen? This inhibition is not there. So this inhibition is not there. So there will be increased hydrolysis and there will be increased free fatty acids. Okay, so it says insulin inhibits hormone sensitive lipase. In the absence of insulin, then inhibition is removed. A hormone sensitive lipase acts on tag in adipose tissue to form fatty acid and glycerol. This free fatty acid undergo beta oxidation to form acetyl-CoA, which enters ketone body synthesis. Now there is increased free fatty acid which will undergo beta oxidation to form acetyl-CoA, which enters ketone body synthesis, leading to acidosis. So this is what is diabetic ketoacidosis. Because of diabetes, because of decreased insulin, what is happening, how the body is going towards acidosis. Let's take this flow diagram, a summarization of what we've just studied, that there is decreased insulin, level of epinephrine or glucagon is increased. So because of decreased insulin, what is increased? Your lipolysis is increased. We've just seen how, because your inhibition of the hormone sensitive lipase via insulin has been removed. Now there is increased free fatty acid in the plasma, which leads to increased hepatic output of ketone bodies. Okay. Moving on to ketone body synthesis. So this is the pathway of ketone body synthesis, that how your ketone bodies are synthesized. So it takes place exclusively in liver mitochondria. The starting material is acetoacetyl-CoA. So 2-acetyl-CoA, they condense to form acetoacetyl-CoA, or the last beta oxidation does not take place, and you can directly start your ketone body synthesis from acetoacetyl-CoA. But if there is a question that what is the starting material of ketone body synthesis and acetoacetyl-CoA is not there in the option, then you can mark acetyl-CoA as the answer. Okay. Now let's have a look at the pathway. So your acetoacetyl-CoA, it condenses with another acetyl-CoA, and the enzyme is HMG-CoA synthase to form what? HMG-CoA, that is hydroxymethyl-glutyryl-CoA. Hydroxymethyl. Okay. And also remember, when we were doing cholesterol synthesis, I told you that HMG-CoA synthase is common to both ketone bodies and cholesterol synthesis. Okay. Now what happens, this HMG-CoA, via the action of HMG-CoA lyase, it undergoes lysis and acetyl-CoA is split, and what is formed? Acetoacetate is formed. Now, this acetoacetate may undergo spontaneous decarboxylation, that is, without the need of any enzyme. Without the need of any enzyme. So it undergoes, this acetoacetate can undergo spontaneous decarboxylation to form acetone, or via the action of 3-hydroxybutyrate dehydrogenase, it can form your 3-hydroxybutyrate. So your ketone bodies have been formed. Your primary ketone body is acetoacetate. This is the primary ketone body, and your acetone and 3-hydroxybutyrate, these are secondary ketone bodies. Acetoacetate is considered as the primary ketone body because it is the first ketone body that is synthesized. First ketone body which is synthesized. And your acetone and your 3-hydroxybutyrate, they are the secondary ketone bodies because they are synthesized from acetoacetate. They are synthesized from acetoacetate. Okay. Now let's move to ketolysis. So almost all tissues can utilize ketone bodies as fuel except liver and RBC. Very important. Okay. So your liver is involved in the, you can see here. Yes. Liver is involved in the synthesis of ketone bodies, but it never itself utilizes ketone bodies. Okay. Now let's have a look at the ketolysis or the utilization. That how does it take place? This is the liver. In the liver, what is happening? Your ketogenesis is taking place. That is, your ketone bodies are being synthesized here in the liver. We've already seen how from the amino acid catabolism, from fatty acid oxidation, from glycolysis, from everything you're getting what? Everything is converging at acetyl-CoA. Now your 2-acetyl-CoA, they condense to form what? Acetoacetyl-CoA. Then this acetoacetyl-CoA again condenses on another acetyl-CoA to form your HMG-CoA, and from this HMG-CoA, acetoacetate is formed, and this acetoacetate, which is the primary ketone body, it forms other secondary ketone bodies. So this acetoacetate on spontaneous decarboxylation forms acetone. So this acetone, it is volatile, it is non-metabolized compound and is excreted through lungs giving a fruity smell, which means that this is not utilized by any other organ. Not utilized by any other organ. Okay, and it is volatile, so via the lungs, it is excreted out through the lungs. Okay, therefore, in starvation or diabetes mellitus, there's a fruity smell. In starvation or diabetes mellitus, you can see a smell of fruity smell. Okay, so from your acetoacetate, your acetone that is formed, it is excreted through the lungs, and the other secondary ketone body, 3-hydroxybutyrate, that is formed. It reaches your peripheral tissues. Okay, so it reaches your peripheral tissues. Now, what happens here? So either acetoacetate can directly reach the peripheral tissues, or your 3-hydroxybutyrate, it reaches peripheral tissues. If 3-hydroxybutyrate reaches peripheral tissues, it is first changed into acetoacetate. Now what happens? This acetoacetate is acted upon via the enzyme thiophrase, and it also accepts CoA from succinyl-CoA. So succinyl-CoA gives its CoA to acetoacetate to form acetoacetyl-CoA, and itself forms succinate. And this succinyl-CoA changing into succinate, this step is a part of TCA cycle. Okay, and in TCA cycle, this step was giving 1 ATP or GTP. But when it is involved in ketolysis, this substrate level phosphorylation is not seen. Now this acetoacetyl-CoA that is formed, it splits into two acetyl-CoA and then this enters TCA to give energy. So that was about the utilization of ketone bodies. I'll repeat this once again. In the liver, what was happening? Ketogenesis was happening. So it resulted in the formation of primary ketone body, that is acetoacetate. So this acetoacetate, it forms two secondary ketone bodies. One is acetone, which is excreted to the lungs. It is volatile and it is not utilized by any other organ. The other secondary ketone body that is formed is your 3-hydroxybutyrate. This 3-hydroxybutyrate, it goes to peripheral tissues and there it again changes into acetoacetate. Now this acetoacetate, this accepts a coenzyme from succinyl-CoA. Okay, this accepts a coenzyme. This accepts a coenzyme from succinyl-CoA. This accepts a coenzyme from succinyl-CoA. This step is actually a part of TCA and is an example of substrate level phosphorylation in TCA. But here what is happening is that one GTP or ATP that was formed in TCA, that is not being produced. So in this step, ATP or GTP not produced when this step is occurring as a part of ketolysis. Okay, otherwise in TCA, this is giving one substrate level phosphorylation, one ATP. Okay, but this step is used for utilization of ketone bodies, then no ATP or GTP is formed. Now, also another thing that here in ketolysis, the enzyme is thiophorase, whereas in TCA, when this step was happening, that is your succinyl-CoA was changing into succinate, then the enzyme was succinate thiokinase. Okay. Now this acetoacetyl-CoA that is formed, it splits into two acetyl-CoA. Now two acetyl-CoA, they will enter into TCA. They enter into TCA and will give you 20 ATP. But one thing to be noted here is that one GTP substrate level phosphorylation here is not taking place. So there will be one ATP less. So from this acetoacetate, which was supposed to give 2 acetyl-CoA and 20 ATPs, you get 1 ATP less, which is 19 ATPs. Okay, and for beta hydroxybutyrate, if it was starting from here, for beta hydroxybutyrate, you will have one NADH which will enter into electron transport chain and give 2.5 ATP. So 19 plus 2.5, which will be 21.5 ATP. Okay, so that was about ketolysis. Moving forward to ketosis. What is ketosis? Normally, what is happening in the body, that the rate of synthesis of ketone bodies by the liver is such that it can be easily metabolized or utilized by the extrahepatic tissues. But when the rate of synthesis exceeds the utilization, the ketone bodies start to accumulate in the body. Okay, this leads to ketone bodies in the blood. They are excreted in the urine, which is known as ketonuria, ketonemia, and the smell of acetone in breath because of excretion of acetone through lungs. So all of these together constitute a condition which is known as ketosis. So that was about ketosis. Now, test for ketone bodies. Rotheras test. Test is given by acetoacetate and acetone. Beta hydroxybutyrate does not give this test. Okay, so this is important. In Viva, usually you are asked, and which of the ketone body does not give Rotheras test? So your answer will be beta hydroxybutyrate does not answer this test. Now, in labs, I'm sure you must have performed this abnormal constituents of urine, where you take a urine sample You saturate it with ammonium sulfates and then add a few drops of freshly prepared sodium nitroprusside followed by liquid ammonia. And you will see a purple colored ring is formed at the junction of the two liquids here. This. So this is Rothera's test. So that was about ketone bodies. I'll end this by taking two very interesting clinical case scenarios. So it says a 22-year-old diabetic comes to the accident and emergency department. She gives a 2-day history of vomiting and abdominal pain. She is drowsy and her breathing is deep and rapid. There is distinctive smell from her breath. What is the most likely diagnosis? So, vomiting and abdominal pain, these are symptoms of diabetic ketoacidosis. Then also says she is drowsy and her breathing is deep and rapid. So we all know that ketone bodies have a low pH. So they turn the blood acidic. So the body will try to prevent this acidosis, okay? It will try to counter this. So the body tries to buffer it with bicarbonate buffering system. The body tries to buffer this with bicarbonate buffering system. But soon this is overwhelmed. Okay, how much can you buffer it? So after this, the body will try to take alternative measures to prevent this acidosis. Okay, so the other mechanisms to prevent it will be hyperventilation. It resorts to hyperventilation, ventilation so that it can wash out blood carbon dioxide. Okay, to lower the hyperventilation, to lower the blood carbon dioxide. So as a result of which there is deep and rapid breathing. So this explains that. Then vomiting and abdominal pain. These are symptoms of your diabetic ketoacidosis. Then there is distinctive smell from a breath. This is because of excretion of acetone. Okay. So what is the most likely diagnosis? Now your answer will be diabetic ketoacidosis. Okay. Because all these symptoms and the history indicates towards diabetic ketoacidosis. Okay. Taking up another clinical case scenario. A 35-year-old woman become severely depressed after the sudden death of her husband. 2 months later, she was brought to emergency room by her friend because of extreme weakness and lethargy. She appeared thin and pale. Questioning revealed that she had not eaten for several weeks. Okay, now this is important. Analysis of plasma sample indicated elevated level of alanine, acetoacetate, beta hydroxybutyrate, blood urea, nitrogen. However, her plasma glucose concentration was low. She was hospitalized, given intravenous feeding, antidepressant medications, and subsequently shifted to an 1800 calorie diet. Her recovery was uneventful. What is the most probable diagnosis and what is the significance of each of the elevated metabolites? So this is a case of starvation, as you can see. And let's see the significance of each of the elevated metabolites that suggest towards starvation. So she had not eaten for several weeks. That is one of our clues. Then another, it says that there is in elevated levels of alanine. So alanine, we all know, is the principal glucogenic amino acid. Okay, it is released from the muscles because it is the principal glucogenic substrate. released from muscles. Okay, it is an important glucogenic substrate. So that explains for the elevated alanine levels in acetoacetate and beta hydroxybutyrate. What are these? These are your ketone bodies, okay? Acetoacetate and beta hydroxybutyrate, these are your ketone bodies, and they are the alternative metabolic fuels. Okay, because your acetyl CoA that is formed, it cannot enter TC because of the unavailability of oxaloacetate gluconeogenic substrate in the previous stage. So they go for ketone body synthesis. Then your blood urea nitrogen is elevated. This signifies what? This signifies protein degradation. Amino group, it is converted to urea. So this explains for the elevated blood urea nitrogen. So what will be your most probable diagnosis? And what is the significance of each of the elevated metabolites? So we've seen why each of the metabolites were elevated. So this is a case of starvation. Okay, so with this, we're done with ketone bodies. Another important thing that is left in lipids is your Refsum's disease. Okay, this is also quite frequently asked for short notes and is important. You get asked about Refsum's disease, but before talking about Refsum's disease, we need to know a little about alpha oxidation of fatty acids. Okay, so where is the oxidation of fatty acid taking place? It takes place, the site is endoplasmic reticulum and peroxisomes. That is where your alpha oxidation is taking place, and there is removal of one carbon at a time from the alpha carbon atom. So unlike beta oxidation, where the two carbon units were being removed as acetyl CoA, in alpha oxidation, there is removal of only one carbon at a time. For oxidation of branch chain fatty acid to remove methyl group at the branch point. So your alpha oxidation is basically involved in the oxidation of branch chain fatty acids when you reach a branch point, and it is used for oxidation of phytanic acid, which is a major dietary methylated fatty acid seen in dairy products like milk and animal fats and chlorophyll. So basically, your phytanic acid that you are getting, that is metabolized via alpha oxidation. So your alpha oxidation is meant to metabolize your branched fatty acids. Now let's see what is Refsum's disease. So there is this particular enzyme that is defective in your alpha oxidation, which causes Refsum's disease. Okay, so basically you do not need to know the pathway. Therefore, I haven't even included the picture because that's almost never asked. So beta oxidation, the pathway is important, and you were asked about that. But for alpha oxidation, you're basically about the clinical aspects, and the cycle as such is never really asked. So I haven't even included. But just to explain you, your phytanic acid in all other such compounds, branched fatty acids, they are first hydroxylated and then they are cleaved as one carbon units, and then that is how your phytanic acid is metabolized. So a particular enzyme that is occurring in this alpha oxidation of fatty acids, that is defective or absent, which leads to Refsum disease. So that was briefly about it. Now let's uh, take some important points about Refsum disease. It is a metabolic error due to lack of alpha hydroxylase, that is phytanic acid oxidase. So this is what is defective. so that alpha oxidation does not occur and leads to phytanic acid accumulation in the tissues. So what is happening in Repson's disease? One of the enzymes, that is phytanic acid oxidase, that is involved in alpha oxidation of phytanic acid, that is defective, and as a result of which your phytanic acid cannot be oxidized or metabolized, leading to its accumulation in the tissues. So now such patients, they have severe neurological symptoms: polyneuropathy, retinitis pigmentosa, nerve deafness, anosmia. Children usually have moderately dysmorphic features that include epicanthal folds, a flat nasal bridge, low set ears, and cerebral ataxia. So these are the clinical manifestations. Okay, retinitis pigmentosa is night blindness, okay, because of damage to your retina, so the person is not able to see in dim light, and when it worsens the person is not even able to see in bright light. Then anosmia is loss of smell. Then regression of symptoms is observed with restricted dietary intake of phytanic acid. So the treatment includes that you need to restrict diet which is rich in phytanic acid. So you need to avoid milk and leafy vegetables that are rich in phytanic acid. Anosmia is loss of smell. New retinitis pigmentosa is night blindness due to damage to the retina. The person is not able to see in dim light. So there's another case study attached to this. A 6-year-old child with progressive hearing loss, okay, was brought for consultation. History revealed that the child was born normal but progressively developed loss of hearing and loss of smell. That is anosmia. Loss of hearing also is there, nerve deafness, okay. From the past few months, the child was finding it difficult to locate things at night time. So this might be because of retinitis pigmentosa. The child had dysmorphic features, a flat bridge of nose and low set ears. So what is the likely diagnosis and what is the defect in this disease? So you see, this is a clear case of Refsum's disease. All the clinical features are exactly the same. And what is the defect? There is defect in phytanic acid oxidase. Okay. So with this, we come to the end of our lipid marathon series. And our next topic will be amino acids and protein metabolism. Any queries, you can send them down in the comments and I'll answer them. Okay, thank you for watching. See you in the next class.